Shalom and good evening. You can see how thrilled I am to be here. Not only is it our 20th show, Rose, you are amazing, but this is Dr. Tova Goldfein streaming live from Facebook, and my amazing co-host from Australia, Rose Hoy.
Good morning, everyone from Australia. Thank you, Allan, for joining us. Dr. Abbass is a leading researcher into pain management, chronic pain, and various other issues. He's joining us today to bring us some more insights into how chronic pain affects us. And I'd just like to thank you for joining us. And my first question would be, why is it so hard for patients, for people, to work out why chronic pain is connected to an emotional issue?
Yeah, well, thanks for having me. I'm glad to join you. We're a real international contingent here. So chronic pain, there's multiple different factors involved, and one of them is emotional factors in affecting pain progression or worsening or relieving of pain is emotional factors. So we're going to talk a little bit about this, and I have a few slides prepared to talk about that. But the thing is that when pain is present, the most obvious thing is the experience of the pain and the physical effect it has on a person and the impact on function. So what the experience is dominated by is the physical effect. So it's difficult in that situation, or even over time sometimes, to think about other factors that might be involved that are a little more difficult to see. So we can talk a little bit about these going forward here. Should we go ahead with a few slides? I prepared a few basic slides here to talk about some of these things, and we can field some questions when we get to the end of those, if that sounds good.
Yeah, I just wanted to, already our audience is between India, Denmark. It's just, I'm blessed with my guests. Yeah. TMS is blessed with my guests, and ISTDP is blessed. So what's going to happen, I'm letting our audience know, as they join our BeLive room and on Facebook, is that I'm going to bring up the slide, but in order to make the slide bigger and more clear, because they're really interesting, I'm going to have to bring Rose and I down off the stream, and it'll just be Allan and the slide, and then you can explain it. And then, Allan, you just tell me when it's time for the second slide.
Okay.
Okay, so first I'm going to bring the slide up. Here's this first slide. Hold on a second. And then I'm going to bring Rose and I down, and you can explain.
Okay, so this is just the first, because I wanted just to say something basic and core about pain, which is that it's a subjective experience. It's experience within the person. And so it's something that is not, can't be evaluated or rated by an external person because it's an internal subjective experience. There are a lot of factors that are involved with chronic pain that we're going to be able to talk about here. And this often means that there's more than one effort that are required to bring pain under control or to remove pain symptoms. The next slide. Just flip to the next slide. Thanks. So one thing about pain is that it's heavily impacted by our expectations. So this here is a man who is a construction worker. He shot a nail right through his hand there, as you can see, kind of gory to look at, but this guy was in the emergency department, quite matter of fact. Okay, there's a nail in my hand. This is a pretty tough kind of guy. He's used to getting injured and such, and it wasn't a big deal for him to say, okay, now pull the nail out. Okay, so in contrast, if we can have the next slide, and I got to thank my colleague Howard Schubiner for a couple of these slides. We'll go for the next one. There we go. So this person here is another guy working in construction, and then he somehow stepped onto this nail, and it's right through, and he's jumping and yelling and screaming, and he goes, the ambulance is called, he's brought in by ambulance, he goes in there screaming, and then they go and cut off his boot, and there's the nail right between his toes. It didn't even actually broach the skin. So expectations have a huge effect, and also other factors that are based on our personality makeup, our life history, some hereditary factors in terms of what response we're going to have to injury and acute pain, at least. You go for the next one. So to think about it as far as anxiety pathways and symptom formation. So in the situation of an acute injury or chronic injury, there are different body systems that are impacted, leading to a range of symptoms that are crossed into various medical conditions and medical presentations. I'm just making this bigger here. So the first is voluntary muscle tension as a type of anxiety in the body. And it starts in the upper body and goes down the body. So it's seen in a person who's there as a client or patient with hand clenching and sighing respirations, raised shoulders, signs of tension in the body. The person can have chest tension and sighing respirations and hyperventilate like a panic attack. Get tension in anywhere in the body on any of these muscles. And this can compound or cause a presentation where the person goes to an orthopedics surgeon or a rheumatologist or a general surgeon with pain symptoms affecting these areas. The next level is smooth muscle, and this is involves the bowel, bladder, and airways and blood vessels. And so symptoms deriving from anxiety here can make abdominal pain symptoms, breathing difficulties, blood pressure changes, and migraine. Headaches, this is a factor that can contribute to migraine. Bladder pain and bladder spasm, I see in urology. And then the next one is cognitive perceptual disruption, whereby the person has mental confusion when anxious, vision gets blurred, hearing is reduced, and the person has fainting and freezing kind of symptoms. And those primarily, when those symptoms are there, they're seeing a neurologist and having scans and images there, or seeing psychiatry. So these different pathways are different outputs of anxiety in the body, which often the person doesn't notice anxiety as being, it's not determined or felt to be anxiety because these are all physical symptoms. So we call it actually unconscious anxiety, and it's a product of emotions being triggered by current stressors, resulting in various body symptoms like these. Can we go to the next slide? So for chronic pain, there's just looking at the top here, or to the left, we're all born with hereditary tendencies and different factors in life that cause our autonomic, which is kind of the automatic nervous system of the body, to have a certain settings. So depending on how ours is set, when there's an acute symptom from any cause, and I mean by a symptom is just an ache or pain or spasm or something happens randomly in the body, it can induce fear of injury or death tied to that symptom. So for example, if there's like a spasm of muscle in the chest, the person can have a fear that they're going to have a heart problem, die from this. And that on its own can begin cycles of fear and avoidance. So the fear and anxiety attached to the symptoms leads to avoidant behavior patterns. It leads to people doing less and restricting their activity. It can induce family members to become anxious as well, and physicians to become anxious as well, till they figure out what the symptom's about. And so that's one whole way to think about this, is from the fear, response, and avoidance cycle. But these kind of patterns and patterns of symptom experiences can be remembered and learned and become kind of habits of the brain and body. So, I mean, think about it. You can all remember if you've ever had an injury where you either had a fracture or a severe injury for some reason. You can remember that and re-experience it. And beyond that, if you tell me about your experience of that acute injury, I can feel that myself while you tell me about it. I can feel that pain without having the injury. So it becomes sort of a habit of the way the brain and body respond to keep re-experiencing that symptom. And the body then gets into a situation where it takes on its own life, and it keeps being re-experienced or even amplified or move around in the body as well. So attached to this on a more, what we would call unconscious level or deeper level, is fear that the pain or the symptom is going to result in loss of people, meaning death or separation, including being separated from physicians or care providers who might get frustrated with the person. And this worry about this fear of being rejected and excluded can be activated. And that itself links to emotions related to being attached to people in the past and having those attachments interrupted. So attachment trauma, we call it, when there's breaks in bonds in childhood. So, for example, if a parent becomes ill or dies, that's a break in the bond. If a parent becomes neglectful or abusive, that's a break in the bond. These bond or interrupted attachments produce so much mixed feelings that are never experienced in the kid. And the kid develops a bunch of somatic symptoms, anxiety, depression, and behavior problems as a result of attachment trauma. The other thing that happens with attachment trauma is the person can't feel emotions or identify emotions. And instead, when things when there's challenges, the body's unconscious anxiety and the autonomic nervous system start to fire. So you can get this process going on on an unconscious level, and you can get these more conscious contributing factors at the top happening. So can we go to the next slide? You can think about it a bit like an iceberg, where at the top you can see, you may be aware that there's a symptom, there's this fear, there's avoidance. You can see these things. What you can't see as easily is the other pieces, that the process becomes learned and entrenched as a habit of the way the brain works. The issue of gain or the threats of loss of people more so, and attachment interruptions, etc. These things are further away from being obvious. Can we go to the next slide? So the other issue that amplifies this thing is, that can amplify pain experiences, is to do with abnormalities of tests. Sorry, just 1 second here. So, did you know? I mean, this is something that I didn't know until a few years back when me and Howard Schubiner started writing this book, and he informed me about these things, is that there's a very high rate of abnormalities of tests, of scans and imaging studies in people who have no symptoms whatsoever. So, for example, depending on your age, it's possible to have a high rate of abnormalities of the neck, like the neck discs bulging on the neck, disc degeneration of the spine, arthritis of the knee, abnormalities of the feet, abnormalities of the hip. Some of these are very high rates in people who have no symptoms whatsoever. So think about it. You get a random symptom. Say you get a severe muscle spasm of your hip for whatever reason, and then they do an imaging study, and then they find that there's an abnormality. Well, the question is does an abnormality have anything to do with the symptom? Or is it just that it's randomly there because it's so common to have abnormalities? But what can happen is the person becomes stuck on the idea of having an abnormal scan, and that causes them to become more afraid to do things. They get more inhibited. they do less, their muscles get weaker, it causes more tendency toward injury. It's a vicious cycle, and this is one of the contributors, is just a misunderstanding of what it means to have an abnormal test. In most cases, it doesn't mean anything, but in some cases, it does, obviously. Next slide. So thinking about treatment approaches, the top one here, and it can have a huge effect, is how the original medical physical assessments are done and how the patients in the medical setting are treated. So a good history, listening to the person, understanding as much as possible what's going on, evaluating them physically, doing a limited amount of tests, doing a proper physical examination, ruling out common things, asking about factors that might make it worse, stress factors, other factors, and then being able to educate a person about this term psychophysiologic disorders, educate a person about how mind and body are one and constantly interacting together, and encouraging them to resume function, okay? So that has a big impact on its own. But for people that don't respond to that, then more interventions to change around these thoughts and behavioral avoidance patterns are warranted. And these can be guided, or they can be self-directed sort of modules or education approaches, or with a therapist to work on thought patterns and behavioral avoidance patterns that are making pain more prominent. So I can give a little sample of this here. So this person I was privileged to work with was having so much chronic pain, and he had been formerly an athlete and had stopped doing things, and he literally couldn't do much moving at all, getting more and more pain, and he was so guarded up and tense. And we did some psychotherapy focusing on emotions that I'll talk about in a minute. But the other thing I said is, do you do anything much? I asked him, and what does he do? He played basketball. I said, do you ever touch a basketball anymore? I said, and I said, what about if you do? Just do something with it. Just think about playing, just bounce it a bit, do something with it. To get him out of this frozen position of thinking he couldn't do anything. And that combined with the emotional piece, combined to make a good result of nice pain reduction and increased activity. So just to say as well, I can tell you a little story about someone who's on this call. So basically, about 15 years ago, I had an acute disc herniation. And I tell you, it was so much pain the first time it happened, mostly with spasm. I could hardly walk. So if any of the people on the call from Washington will remember, because I was on the way to Washington, D.C. to give a talk, and I had so much spasm I couldn't walk. They actually wheeled me into the lecture hall to present, okay? So that resolved within a few days, and but then it seemed to come back a few more times. And gradually I stopped playing sports myself. Because it seemed like I was doing less, and then I would get more sore, so I just kind of gave it all up. So I got to thank my TMS colleagues and Howard specifically around, and Dr. Sarno, obviously, who's influenced everybody. What can I push the envelope? What can I do? And the whole idea of stopping anticipating injury, just get that out of my mind and started doing things. And so as it stands, like over the last 4 or 5 years, I run full court basketball. I'm 58 years old, and I'm sure my back on the MRI looks like a mess, but who cares? I don't care. You can do better than our MRIs a lot of the time, and that's kind of where education and other approaches, the TMS approaches, my colleagues have, and for people that don't respond to those interventions, or there's another emotional factor that I spoke about briefly, is trying to identify and process underlying emotions that make the body stay in this frozen, anxious position. So help the person identify feelings, be able to feel emotions. Inevitably, that the work ends up talking about childhood adverse events, to try to clear those out. And that was the work that Dr. Sarno, obviously at some point was influenced by Davenlou and one of his colleagues who trained with Davenlou, Davenlou being the person who originated ISTDP. But this is one type of psychotherapy. Psychotherapy that doesn't need to be called this, that focuses on emotional processing in the room, is going to be helpful. There's a model that is tied to this ISTDP and has other cognitive behavioral approaches called emotional awareness expression therapy. That's also demonstrated to have good treatment benefits, as is ISTDP proper, as 20 outcome studies for a whole range of physical symptoms, including chronic pain. So is there another slide? I think there's one more. Yeah, so the other thing, this is a broad issue, is rejection and pain. So we are wired to stay in the village to survive. In other words, if we, back in prehistoric times, got tossed out of the village, it wasn't good, you could die. So we developed this part of our mind that needs us to stay accepted and included to feel safe and relaxed. So if we experience rejection from somebody, or a threat of rejection, or we are self-rejecting in a sense, it makes pain signals go up markedly. So you can actually experience pain from rejection. So for example, there's research showing that if you do an experimental design whereby people experience rejection with doing this little video game, if they get rejected by this, they have more pain when they do the testing. And that kind of rejection, pain, was actually improved by Tylenol, if you can believe it. So Tylenol for rejection, we don't need chocolate, just some Tylenol. And so the opposite is true here too, is acceptance. Self-acceptance of what's going on inside oneself, acceptance from others. That means the physicians, the care providers, to accept that this is what's happening, to accept the person going through it, and to validate those experiences. That brings pain relief on its own. So I just wanted to toss that out there as well, because that's like a brain and interactional pattern it's hardwired in our brain. So, okay, so those are a few thoughts, and how about we can open it to any questions or comments I guess people have, or if you, Tova and Rose, have any comments, questions?
Well, I'm really happy
about
your back pain. You made yourself a bit real. I'll put my headphones in. Anyway, a little bit of an echo. Rose, go ahead.
When you, my original question about finding it difficult
I can't hear you.
to connect. I
can't hear you.
The initial.
Okay.
Oh, okay, now. Yeah, I can. Okay.
Yeah.
Okay, good.
I said my original question about how difficult it is for patients to connect to the emotion. What you're actually saying is that the pain is so intense that they can't think beyond it. Is that what you were saying?
That's one reason, is the pain can be so overwhelming that they can't think internally on emotional processes. The other is that this inability to identify and feel emotions, it makes it so hard for a person to be able to see them. The other is that when there's a lot of attachment trauma, trying to work with another person is so threatening on a deep level that the person recoils away and blocks the contact because the feelings coming up are so intense and painful. So they can't feel interpersonally related emotions. So when you try to ask about it, they involuntarily become uncomfortable, tense, maybe sick in the stomach or confused. So it's hard to reach those feelings. But that's where the therapy comes in, to help them calm themselves and identify in an accepting way whatever emotions are triggered interactionally with us. We're there, a caring person. It triggers all the feelings about being cared for in the past or not cared for. Those all come up at once, and then the person's body reacts to show that there's a lot of feelings going on, and we help the person settle and see those and work through those.
The other question in that regard is, could you talk a little bit about isolation of affect, how patients, but use everyday sort of language, about how patients know they've got a feeling, but they don't know.
So
I think it's in their head rather than the body.
Okay, so when a person is intellectually aware of emotions but don't feel emotions, what ends up happening is the person has a lot of feelings maybe stirring up. They may be very tense, and they can tell you intellectually there's feelings, but their body just gets tighter and tighter and more sore in some cases. So that you try talking about feelings, it doesn't really go anywhere. It can even get them more stiff and sore. The key there is to help them feel the emotions that they're tensing up about. Now, that could be a challenge if the person's in a lot of pain, but to help them settle enough to be able to identify the emotions that are coming up, that are making them so tight and contributing to their pain experience. So that is, one way of distancing from feelings is just talk about them and not feel anything. And that, again, is a learned pattern from childhood, typically.
Yeah. And also the whole idea of that being protective. Can you sort of explore that a little bit more for people? You know how like that pain becomes a protection from your feelings, and so it's a benefit, well, a weird benefit. That
so symptoms that come, like I listed all those different body symptoms. A lot of those are pain symptoms. When emotions are going into those body areas, the person doesn't have any painful emotions. They have a painful body. It feels horrible, but they're not feeling any emotions. The emotions are being caught by body systems and just stuck there. So, so in that sense, they're protected from feeling painful feelings and scary emotions, such as anger that's really intense, and guilt about anger and other emotions. So they're protected in that sense. But it's a tough way to self-protect, and it becomes such a habit the person doesn't even know they're doing it after a while. And that's where another person needs to come in, a family member, friend, therapist, somebody to help them see that there's something going on there.
Yeah. Well, that's probably one of the hardest things for patients, isn't it, to move into that space and have that empathy that there's something wrong.
Yes, and there needs to be a good trust built with whoever the professional is to be comfortable enough to start to move into some of those tough areas, or even to believe what the person says when you help them see something. There needs to be an establishment of some trust, that you have some idea what you're doing and that you have their best interest at heart, even though you may be asking them tough questions and pointing out things that are hard to see. So that's a challenge too, because the more a person's been hurt, the more they're desperate to be helped, but at the same time terrified of it. So that's the double edge. They're there and they're terrified that you're going to help them. They're terrified you're not going to help them. They're terrified you're going to accept them. They're terrified you're going to reject them. And this happens so implicitly or unconsciously or automatically, it just becomes the way life is for a person. So, it's a big relief when somebody helps them see it, but at the same time, it's very tough and painful to see these things. And just to say,
it's a sort of breakthrough.
And just to say, we're talking about pain here, and there are more than one source of pain. So, there can be pain on top of emotional factors, and there can be pain without emotional factors. So obviously pain causes an emotional factor, it causes distress. But one thing is, clinically, we don't make an assumption that there is or isn't any emotional factor. We just find out by interviewing a person and then seeing how they respond. But we do see people who have symptoms that has nothing to do with emotions. It's just the way it is. There's symptoms that have other causes, or can have 2 or 3 causes, and then you can treat 1 or 2 of them, and then you got to do other things for the other symptoms.
Yeah. Well, a lot of the patients that talk to us over the internet, they've been to see 25 doctors, and I'm always intrigued why 25 doctors haven't wondered why they haven't come up with a conclusion, because I'm sure the patients told them about the other doctors that they've seen, and I thought, what about doctors anxiety about getting it right?
Well, I mean, it's a big
It always intrigues me.
There's a big educational deficit in medicine. I mean, this is not widely taught. I mean, this is part of why Howard and I wrote that book, Hidden from View. It's built to go in a lab coat. It's just the size. It's built primarily for docs, but any health professional, but it's built for giving them a basic overview and understanding of these factors that I just outlined on those slides. So they have that information, because it's just with that information, they can do something at least. And when I teach family physicians about these things, they're always like, they're like shocked. It's like, why wasn't I taught this? And a lot of them have an idea something's there, but they don't know what the heck it is, and they don't know how to go about interviewing it. So that's where education modules are key for physicians, because especially physicians, because they can prescribe, they can refer for painful procedures and investigations. They often hold the purse strings for costs. So they really need to know about this factor.
Do you think, leading on from that comment, that you talk about the cost to patients, the not just the emotional cost, but the financial cost, and then the work you've done with the Canadian government to try and make the ED departments more accountable to emotional issues as well? You've done a lot of research there, and I think our viewers would like to know a little bit more about that and the progress that you've managed to make in Canada and maybe elsewhere.
So we've been able to demonstrate that when you do work on these factors and evaluate them, people have a dramatic and long-lasting reduction in healthcare costs and healthcare use. In the States, if people have to pay for it, they directly would be saving the money. But in Canada, we don't have to pay for healthcare; it's all covered. But the government saves, I think it was $17 for every $1 spent just in reducing doctor and hospital costs. And that was a study of almost 900 patients treated. So in the emergency department, we showed that there was a 70% drop in repeated emergency visits with physical symptoms, and that won a Canadian recognition as an innovative program. And so that's been adapted a few places to some extent, and it's used. But the other broader research is on chronic pain, showing the major healthcare reduction as well in follow-up. There's other range of other conditions, including depression and anxiety, and a lot of different somatic problems, physical problems. So added together, there's like 25 cost studies pointing to benefits. So it would be to the interest of governments who have to pay and people who have to pay. But I hate to have a jaded view on it, but sometimes it becomes reinforced to have a treatment that never actually cures a problem, but just keeps it going. And I mean by that is, for example, pharmaceutical industries, they don't want to see people cured. If the medication is going to be stopped, they are unmotivated to do so. So there's different forces at play. I'm saying, for example, spinal injections, the evidence is pretty scant for that overall. And even certain spinal surgeries, the evidence is questionable there, and procedures and all these things that it ends up someone's paying for it all the time, and people are going broke trying to get help for their problems. At least the emotional factor should be looked at as one doorway, and at least the thought and behavioral factors should be looked at. And this is what Dr. Sarno found in his work. There were so many people that he could do what was a powerful educational experience, educational kind of effort, and a few other things. And see the benefits that he saw over his career.
I want to just say I'm really appreciating you talking about this, but maybe on your way home tonight you need to wear a bulletproof vest. Though I forgot you're 6'9". Okay, I think it's going to be fine. It's the truth, and it's a double-edged sword, because we're not against medication, you're not against medication, but
No.
surely if people work on their emotional well-being, the medication will work better.
Yeah, either medication works better, they need less, or they can stop it, and in some cases they don't, and they need it. And it's it's the same for anxiety and depression, by the way. Here, like, there's a significant overuse of antidepressant medications in some regions of Canada. Okay, those same regions have a real shortage of psychotherapies. So do the math. People who take pills, a course of brief therapy is the same as the cost of 1 year of antidepressants. Well,
Wow.
let's see if we can change that around a little bit and bolster the person's capacities to, as much as possible, manage their mood, manage their anxiety, okay, manage their stress-related symptoms. Then take it from the other purse where the person's paying for pills. In our system here, the medication's paid by one part, the healthcare comes from another part, and the two don't talk. It's the same as disability, by the way. Disability is a huge burden for people with chronic pain. And it's a burden. Basically, the insurance companies lose the money, but they don't provide the healthcare in a lot of cases. So you got this disjointed system that doesn't really meet the patient's needs. So it's a real problem. I think it's a problem in the most organized societies, that disparate parts of the system don't help people to get well as much as they could.
Maybe we can share. Go ahead, Rose.
No, well, you go from. Why have we got this echo? Okay.
I'm not sure. It's been going pretty well for now, but I'm always blessed that we've gotten this far. But try again now, Rose.
I was just commenting that, unfortunately, when patients are sent from one specialist to another, that's the breakup as well. You're talking about government departments, but in actual fact, it also happens in medicine, doesn't it?
Ping-ponging from one physician to another part of the system. Oh, yeah. I mean, the better integrated systems have professionals that do this embedded into their system. And we've tried to do that. There's efforts to do it. It's just difficult to change the system. We've done it successfully in the emergency department. So we have a psychologist sort of embedded in emergency, linked to emergency. And that's been very successful, doing it that way. But you have to make changes in the whole system to do these things. Some countries, by the way, are much more. Some countries and jurisdictions are much more nimble at these things. By the way, some of the Scandinavian countries, they've been more successful, I think, at making some of these changes than other countries. Maybe partly the smaller government, but I think also just more forward thinking as well. So, shout out to Denmark, Sweden, and Norway.
That's right.
I want to ask a question. I think that we have a lot of people viewing, not a lot of people questioning, because it's fine. But Rose and I, we're our purpose is really to help people heal themselves, and for us to be messengers or conduits in that. And so it's not easy to feel your feelings, to be in touch with your feelings, to acknowledge, recognize, So if there was some take-home tools you could share with our listeners, like, let's say they're in therapy, but the rest of the week they're on their own. And so I always think about, well, we're learning a new habit, we're learning a new language, self-acceptance. So what would be maybe some tools to help some of the listeners?
So one thing is, I don't prescribe this, but I know some people find it very helpful is journaling, writing down things. And there's different apps that help you with this. One you've heard of is Curables, that's been informed or helped out by some of the TMS leaders in the treatment group. So writing is one. meditative practices of different kinds can be helpful too. Exercise is really helpful. But you need enough stimulus, I'm going to say interpersonal stimulus, to get emotions moving that have to do with past relationships. But something that is generally helpful is actually doing something good for yourself or someone else. Kindness to you or someone else stirs up all these attachment feelings, and it can give you a window into it. So if a person's used to sort of self-depriving for years,
Wow.
I'll actually say, so what happens if you do something really, kind and good to yourself and treat yourself differently after this meeting? What's going to happen? And then you see the anxiety goes up. Okay? They're anxious about doing something kind and self-caring because it triggers so much deep emotion. But they have to start to do that, you see? So it involves taking care of ourselves and someone else as a way to deal with being hurt by others in the past. That's kind of a sort of a shortcut way to go. So you can do that at home. You can do that with someone. You can write things. You can observe your own body. So these things all add up to something on their own.
Yeah. So this is a question that's very global, very general. Maybe you can mention it. This next question: how effective is ISTDP? Ask Julie Winner.
So there are about 40 high quality, what are called randomized controlled trials of this treatment. It outperforms other bona fide treatments as a comparison when they do head-to-head studies. So it has a better effect than supportive therapy, medication management. There are 5 studies of it for chronic pain, and it outperforms cognitive behavioral approaches. So it's very effective. Large treatment effect sizes. The effects tend to last in long-term follow-up. So it's pretty well researched. I mentioned the cost effectiveness data. I'd say from a study I did and one that the founder did, a little over 80% of people make gains and keep them in follow-up.
Wow.
So that's quite a high number in comparison when you consider these are people referred to a psychiatrist from mental health services usually. So it's not a panacea, nor is any talking therapy, because again, it only touches on certain factors, but it's got a good evidence base, really. It's the most effective method so far for treatment-resistant depression. And almost every patient in a study we did had chronic physical symptoms and chronic depression. So it's got the highest remission rate in follow-up of any study published yet.
Wow, amazing. So this question is from Victoria, and my guess is she's from somewhere in Norway, Netherlands. She says, I've been thinking about the psychiatric care and where the doctors are more interested in diagnosis and medication, which is giving the patient more experience of being neglected in contact with the one who's going to help them to heal. This must give them another attachment trauma and defense.
Oh yeah, there's no question. True. People have trauma in the medical system. It's just it happens for multiple reasons. But one is, hanging on to trying to find a diagnosis, and even like a psychiatric diagnosis. We try to avoid diagnoses, although for research you have to describe something and have some grouping of some sort. But it doesn't help the patient necessarily to have most of the diagnoses that we give. It's, as soon as the physician is in the interface with someone who's had a lot of attachment trauma, it wakens up their own attachment trauma. And so that's what becomes tough for the doc. They're having all these emotions show up. So for example, the patient comes in, the one they've seen 30 times, and nothing's getting better, and they get nauseated when they see the patient on the list to come in today, okay? Or they get a headache, all right? So there's a lot of effect of their own attachment trauma, their own past interactions that are sometimes unresolved. And, that's where you see this 50% burnout in physicians, a lot of problems, a lot of them, various mental health problems in the helping professions. They thought they were going in medicine to help people, and then there's all these people who just don't respond to treatment. Well, that's not what they bargained for. And I mean, I remember it myself. It's like, there's something else going on here, and I'm frustrated as hell, but what's going on? And I was a family doc, and I used to work emergency too. It's like, this is not from that. I'm thinking, what the heck? So that's why I was so relieved to learn about these things, to be able to actually do something. And when people are coming in and it's a strong emotional issue, that was just showing up as a physical format. But, without education, it's a problem. A lot of physicians, when they learn about this, they get themselves some sessions or read stuff, and they have, you present this stuff, show videos, they're out there wiping their tears and all, it has an emotional effect on them to learn about these things. We're all people here. It's not so.
Amazing.
Yeah.
So here is a woman. It's a beautiful name. I'm not even going to try to pronounce it, and maybe she's from India, but welcome. This is her question. Naha Agarwal, beautiful name. Often patients on high-dose anti-anxiety medications along with psychotherapy. How does that affect their experience of symptoms of anxiety or pain during the ISTDP session? Good question.
Yeah, so certain medications can make it harder for emotions to activate, and that's part of why they're prescribed. So some antidepressants, some of these like anxiety medications, they slow down the rise in feelings or blunt the rise in feelings. So it's a trade-off they have. They have less anxiety, but they're numbed out, and it really bothers people after a while to be numb. But it's a price they've been used to paying for anxiety reduction, and they don't know any other options. But once you start to work with them and they can identify and process some emotions and see their body get really calm, they say, well, how do I get off this medication? And most of the time we're able to reduce or stop these. Mm-hmm. So they can interfere with some psychotherapy approaches, but not always. So there are situations where you're going to prescribe both, but I can tell you for every pill I've ever prescribed, I've stopped 20. Wow. So I don't get a lot of pharmaceutical company money for my talks, but they do sometimes support. They have a guilty conscience, so sometimes they'll pay for a talk.
Don't forget that vest, that bulletproof vest when you leave tonight.
Yeah.
Okay. Here's Jane. Jane, I'm so happy to see you. And here's Jane's question from Germany. Does our subconscious choose specific parts of the body or certain symptoms to want to tell us something special?
Oh, yeah. I'll just put it this way. If people have anger and a stored up impulse to do something to hurt somebody in a certain way, when those feelings come up, they might feel the same symptom on their body. So one example is a person who boyfriend harmed her in a very specific event. And as soon as she started to talk about it, she got a sharp pain on her head as soon as she talked about it. And then when we focused on the incident and focused on when she was able to feel this anger go through her, I said, so what did your anger want to do? It wanted to punch him right there on the head, exact same pain symptom. Wow. And when she felt that, this pain symptom went away from her head. But that's just one of a ton of different kind of symptoms. So people with choking symptoms, people with pain in the neck, people with stabbing chest pains, crushing chest pain, various other symptoms that are unusual for a medical complaint, burning feet, a person with burning feet. And when the anger is there, they wanted to put the person on the fire with the feet to be burnt, And then when they feel these things, the symptoms go away, which is fascinating. And it's shocking to the patient that they had this for so long, and now the symptom goes down or goes away.
Wow.
So that's one way of symptom formation, is just to have the same experience in the body, sympathetic experience.
Mm-hmm. So
you've got an invitation to India, I see here.
Yeah. Send the tickets. The three of us will come together. TMS RoundTable.
No, not at the moment.
So, Doctor, I can't even say, yes, wonderful. So, have you been to India? Did you teach in India?
I haven't yet, but I mean, I know there's a great group over there who are very interested in all these things and learning. So, yeah, some are coming to the online courses coming up. So,
right. Here's a message from we had this wonderful doctor as a guest,
Sunita,
and she's
hi.
an author, and she's commenting, so great to see you, Allan, giving this vital information as someone who has successfully gone through ISTDP for attachment and complex childhood trauma. I will say that a patient's will is a very big factor in therapy, helping, as this is the skill of the practitioner.
Yep.
It is about a relationship being built, and I found it not to be a straight line towards success. Many times it is secular or feels that way, but the unconscious is processing the healing and changes being made in one's brain. So true, Sunita.
Yeah, for sure. Thanks for sharing that. Absolutely.
I think one thing that we Rose and I will talk to people is, the journey, and I call the journey life. I think the tools that we're talking about right here tonight and that we've been talking about on TMS RoundTable they're tools for life, because, maybe you can talk a little bit about when somebody knows themselves, they can heal themselves more effectively. And some of this work is about knowing oneself, and that's a life process.
Yeah.
Well, maybe you could talk about defenses in that regard.
Yeah.
Yeah. So, again, if we're harmed by interpersonal trauma as a kid, then it becomes almost impossible to know our own emotions. And without knowing our emotions, how do we know what we really want? If we don't know what we want, how do we know kind of who we are, in a sense? So the development of the person is impeded by not knowing their own emotions, in part. So absolutely, these things go hand in hand. The self-knowledge unfolds. It can unfold over time, or sometimes quite quickly, depending on the age of the trauma. And the earlier the trauma, the harder it is to recover from it. Not recover from it, but it takes more time to work through the trauma. And to develop oneself thereafter, getting rid of the impediments of the trauma. Later trauma is relatively much more easy to overcome, in a sense, and shorter treatment. So, we don't choose, we don't have anything, it's not our fault about what trauma we've been through. Or what people have done or haven't done for us. You know what I mean? It's not the fault of the child. It's not the fault of the person. So it's, but unfortunately, the only person that can kind of carry the lead role in orchestrating the recovery is the person. It's a terrible thing if you think about it. It's one burden and it's another burden. But, there's people to help out. So that's why there's...
Maybe... you had that slide earlier on about the severity of the symptoms. Would you sort of mention a little bit about how those symptoms, like if they're earlier on, the CPD, and later, like it's more striated muscle, the trauma could be at 6, or it could be at birth, or it could be even in utero.
The earlier the trauma, if it's really early trauma in infancy, then the person's going to have tendency toward confusion, visual blurring, hearing loss, and fainting attacks if they're really early trauma, early attachment trauma. From age like 2 to 4, the person can end up with a lot of like smooth muscle stomach effect, bladder problems, blood pressure problems, migraine tendencies. And then after age 4 or so, it tends more to cause muscle tension symptoms. So it can be spasms and pain and stiffness in the muscles. And a person can have all three of those too. So it's possible to have trauma at all these different levels of time or different levels of severity. So if a person even later in life has a severe trauma and they can't process the feelings, it can cause visual blurring or things like this, or severe stomach upsets around that event. So, yeah, so it's kind of
Another thing that patients often want to know about, that they'll go straight into their childhood trauma, but in a way, it's really in the present moment that they need to recognize their trauma. Can you talk a little bit about that? Because they spend a lot of time saying, but my family was good, I had a good childhood, so why have I got this trauma? So they're intellectualizing about the pain and trying to go back there. And then, like, when I talk to people, I sort of say, well, what's happening between you and me now? Let's look at that. And could you talk a little bit about that?
So when the approach we're talking about here, the ISTDP model, we're interested in body responses of unconscious anxiety. So for example, the person says, I don't have any irritation with my mother. Okay. Now, you see, you're getting two messages. One is that they're saying they don't have any feelings, but then their body is showing all kinds of signal that there's so much feelings coming up. And so we go to help the person notice the body responses. And we do that in the here and now. We do it in the context of the relationship with the patient, the back and forth together. So you use the relationship as a catalyst to bring forward all the emotions that are coming up. And then you see the body's unconscious anxiety. So for example, before the person comes to the first meeting, they have nausea and diarrhea before walking into the office, So what was happening on the idea of coming in? Or the person comes in and they can't see, literally almost blind from anxiety when they walk in the office. Okay?
Wow.
And again, this has nothing to do with you because you didn't even know them. They're in the waiting area and they can't see. So these are powerful effects of potential attachment with you and the feelings they're really afraid of. Depending on the pathway, we're going to help them either settle down the body or else we're going to help them push through the tension and identify the feelings.
Beautiful.
Help them,
Beautiful. This is from our friend in India who's got tickets on the way. They should be here overnight delivery. In the meantime, here we are on BeLive. Do we have any protocol available for substance use disorder that you can share? I have read about your research briefly where it focuses on defense work and effect work with great outcome.
So I always say my brother John Fredrickson, who you had speak here not so long ago, I worked with him. I mean, I helped him a bit on this, the study that they did out of California. I think it was California. We have a couple studies on substance use, on substance addiction, and the results were very good. High rate of sobriety at 6-month follow-up for a very ill population with like major psychiatric problems. So the whole protocol is built on improving anxiety tolerance, dealing with projections and fears of what people are going to do and interact and how the people interact with those projections. So it's a lot of work on partly reality testing and improving the thinking patterns that escalate anxiety and trying to improve emotional access to a degree. But there is kind of a manual that John built, and he's taught people this. He had a whole protocol where he educated drug counselors. So I had a good result, and there's another study coming soon.
Great. Jane says, I think that new adult trauma can trigger very deep old childhood trauma and then awake them and then provoke chronic conditions in the body.
Absolutely. Absolutely, that can happen. So for example, a person has a fracture, a severe fracture of the leg, and then they're laying on the ground. There's no one around. and they don't know if anyone's going to hear them. They start yelling out. Okay, you can imagine, okay? And there's no one there. They have to drag themselves to the car with a broken leg and drive somehow to a hospital. Okay, this is sort of a story. I made that. It's a mix of 5 stories. But the thing is, it's terrifying, and there's no one there for security. And where are the people that support me? And I'm in severe pain and I need something. All those feelings are coming up. And that's a real situation where chronic pain is going to be like almost guaranteed outcome until those feelings can be processed of what it was like to be desperate, laying on the ground, right? And unable to get cared for by anyone. So you can see it that way for sure, as activating new trauma, activating old trauma. That's the norm, but sometimes it's not always. It's not always that way. Sometimes the acute trauma does something on its own. It's just severe enough.
Wow,
Yeah.
amazing.
Yeah. Well, it brought me to mind our last guest, Jonathan Neer, and the dolphin boy, and how his acute trauma was cured by the connection with the animals, and how if anyone wants to have a look at that, it's an amazing movie about healing through connecting, with dolphins. Yeah.
Well, Allan, do you think? I mean, I say this very broad statement, and I rather believe it, but I'd like to get your opinion in the medical field. I don't believe chronic pain is normal. That it's something people have to accept.
So chronic pain, by the time chronic pain sets in compared to acute pain, the whole brain regions involved in maintaining it are totally different regions of the brain. There was actually a study done by a colleague who now lives here in Halifax, I just found out. Dr. Hashmi was one of the lead authors, I think. So the region involved is more around memory and emotions. So what's happening is there's memories and emotions and trauma, and it's all tied into a different part of the brain than acute pain. So you can imagine acute pain management, you treat that with narcotic and with analgesics, with whatever. It's totally different. I'll tell you a little something. I'm sure my cousin wouldn't mind it at all. We had a little thing there at the cottage a few weeks back. Boom, fell, broke her arm. Broke it. Okay. So I go over, and then I can imagine this is horrible, painful. And so I'll tell you, I just took a very calm position, and I just did all my acceptance stuff. And I put a splint on it, and the pain went away almost markedly. Just by doing a few things, and not being terrified, and you know what I mean, and not being mad at her for So anyway, it's just sort of these. So accepting, that's acute pain management. You see, acute pain management with acceptance drops acute pain too, as well as chronic pain. So it's just a necessary part of healing, is being accepted by somebody and self-accepting. So I'll leave you with that one, maybe.
And not being recoiled.
It reminds me of a story. It might have been one of Dr. Schuberner's stories, but or there was 2 different people with 2 different injuries, and one was a soldier who broke his foot in some kind of exercise, and he was just in a lot of pain, but he was happy to be going home to heal. The same injury happened to a gentleman who was on his way to a dance party, and something happened. He fell and he had an injury, and he was not going to be able to go to a seminar he was hoping for. And so he was in twice as much pain. The boy who fell, at the party, twice as much pain. It lasted twice as long. Same injury happened to a soldier who was coming home on a plane to rehab at home. And it was the same injury, but it was a different situation and a different response, a different reaction. And there again is a situational.
Yeah. And I mean, it's so many variables, there's different factors involved in the two people. Like I say, I mean, I've seen people with fractures come into emergency and they don't have pain. I was like, that's not hurting. You know, you look at it, you say, he said, no, it doesn't really hurt that much. It's like, how is that possible? It's just the makeup of the individual is different, you know?
Yeah.
So.
Yeah. Here's a question from, no, there was another question. Let me bring Gail's up first. Any research on early trauma and adult benefits of pet support?
There might be, but I'm not familiar with that literature. There probably is. Maybe someone else on the call knows. I really don't know.
Well, in palliative care, they often bring in animals, and patients settle, and it's often better than the morphine.
Right. Well, this is a good question for us, Rose, from our friend in India. I'm wondering if ISTDP can be adapted for group analysis therapy. I know we use it in a small group, and it's so effective. Is that what you think he's meaning, Rose?
Well, there's a big study, as Allan probably can tell us, in Holland about Kees Cornelissen has had some wonderful results out of that I've seen, and there's probably more out there. And I think John Fredrickson has got with the alcohol in patients. It's all group therapy, isn't it? I think.
Yeah, there are some group studies. One for chronic back pain, one for there's different ones for pain. There's not so many for pain. So many for group studies, but there are a handful. And Kees Cornelissen's data, even 10-year follow-up, showing the symptom reduction over lasting that long in follow-up. It was group and individual work combined. It's a little bit, it takes some adapting to use this method in group. But just to say, I had the privilege to train with Mullen Lesh, who's Lesh in Yalom. Yalom's kind of group model, I was struck that it was doing some very similar things to what our model does in a one-on-one treatment, meaning mobilizing unconscious processes and emotions and attachment trauma. This was happening in the context of that model of group therapy. So well-conducted group therapy is going to do this similar thing, as long as you have the group set up right and you do certain things to make it possible. It can be highly effective, and groups can do things individual therapists can't as well. So there's benefits there that are beyond individual therapy.
So true. True.
Even if some processes are harder to do in group, and emotional processing can be harder in group, but other things are very good as well.
Awareness is good in a group too.
Mm-hmm.
Yeah.
Yeah.
So usually when we start to wrap things up, some people come on with other questions. So I'm encouraging anyone to ask anything to any of us. We encourage interaction and love that our show is helping many people heal. Anything else you want to say, Rose? Or
well, Texas has got any literature or article.
Oh yeah. There you go. Texas,
and I presume there is on Allan's website, maybe.
Articles available. Yeah, if you go on my website under publications, there's a link. Oh, it's allanabbass.com, ALLANABBASS.com. That's the short way to get there. And then publications. Okay, it's got research summaries. It's got also a link that is linked to over 100 of my articles that are just freely available, and it's got some that are right there. So, and there's a way to sign up, and I do every so often I do research updates if you want that kind of thing, and it'll go by email to you.
Right. Yulia, also before I saw a question asking about a ISTDP therapist in Toronto.
Pardon? You're asking if there's a therapist?
Yeah, an ISTDP therapist in Toronto, she had asked earlier on.
There are. Am
Are?
I going to say some names here on the?
No, I think just that she can go to your website and ask you. She can ask a question, or she can email Rose.
Yeah,
also
there are people there. There's some teachers there, and there's some people who've been practicing a long time, and then there's people that are training with us, and there's others as well. So there's definitely people in Toronto. And someone's asking about a book. Is that the next question?
Yeah, on AI-ISTDP. Would that be hidden from view?
Well, hidden from view is sort of, it's got a combination of all the things we talked about in here. So it's written by me and Howard Schubiner. So it's got this sort of, people have had pain reduction reading that book, which didn't even intend it specifically to do that.
Yes,
but
it's very good.
It's kind of, so that you can get from Howard's website or Amazon. It comes as an ebook or whatever, but it's kind of got a condensed version of ISTDP. It's about half of that book. So that's kind of one place. The other is a more elaborated book, is Reaching Through Resistance.
Oh, wow.
That's that one. And so that one there it's kind of a detailed manual of how to apply the treatment model. It's got a lot of case vignettes in it. It's available in several languages too, by the way. Not in Indian yet, though. We need someone from India to translate it. Literally, it's in Greek.
It's a fantastic book for therapists.
It's even in Australian, Rose.
Yeah. How about Allan? How about a movie documenting Dr. Davenlu?
There isn't one. There's
Should we get Michael Galinsky on this?
That would be great. Now, there's been talk about that.
Really?
Well, different conversations about it. Something might happen at some point, but nothing specific yet.
Okay. So Jane had a question, and Jane, don't ever feel like you can't ask questions. You ask as many questions as you want. Jane, is the biopsychosocial approach a medical label for TMS? I see there are many similarities, but still not 100% enough. It's an interesting question.
Biopsychosocial model just means that when you do an assessment of a person, you consider physical factors, psychological factors, and social factors. And when you do an intervention, say as a mental health provider, you consider all of those. And particularly psychiatrists should be considering all those three. That's all that term refers to. But all the treatments for the main treatments for pain symptoms are they're biopsychological, or they're also biopsychosocial, because sometimes they involve family member education or stuff, do things with the family, or at least it's psychological and biological in some way.
Right.
So
wonderful. Wonderful. So Rose, I think everybody's asked enough questions. Getting that echo again.
If there are any other questions, if you put it on the Facebook page, as it's early morning in Australia, I'll answer any of them or respond to them.
Wonderful.
So that's fine. And Allan, thank you so much for being here. And I think that your description of the whole system, you explored that really well, and I hope that people will be able to go back onto the TMS RoundTable YouTube channel and actually re-listen to you. And hopefully those slides will show up as well, so that they can get a better view, picture of it. So,
Okay, great. Well, thanks for doing this.
Terrific. You're always welcome back. If you get some downtime, Allan, you have nothing to do some days, you can just call us up.
Okay.
Thank you so much. Good night, everybody. Good afternoon. Good morning. See you next week. Bye-bye.
Bye.